Okay, the Davis Award recognizes the successful EMR use, EHR use. A recent winner demonstrated a significant avoidance of medication errors because of barcode scanning, $3 million decrease in medical records expenses as a result of going paperless, and a 5% reduction of duplicate lab orders by using computerized provider order entry alerts, which is great. So, it's going to cut down on waste, which is nice. And then the error thing is huge. The scanning, the barcode scanning, reduced, when I worked at University of California, San Diego, reduced meta errors by 100%, meaning they went a whole year without any meta errors. That's insane, okay? Because I just remember the crazy amount of meta errors that we used to have. Another Davis Award winner noted a 13% decrease in adverse drug reactions through the use of computerized physician order entry. And there was a decrease in MRSA, so MRSA, nosocomial infections from 9.8 per 10,000 discharges to 6.4 per 10,000 discharges in less than a year, because they used the EHR flagging function that made clinicians immediately aware that contact precautions were required for these MRSA patients. And there was actually built into an EHR, I'm sure some of you will attest to this, they have a survey that calculates the risk of patients who might be carrying MRSA so that you can swab them and put them in contact while they're in the hospital. And if it comes back negative, no harm done, take them out of contact. And I know working with a contact patient is such a pain, but at the same time, you're going to reduce the risk of the MRSA infections, which are deadly. Especially for you guys. We don't want to bring that stuff home, although I swear I'm probably colonized in it. So ownership. The process of becoming a successful owner of an EMR has multiple steps, and it requires integrating your EMR into the organization's day-to-day operations and having a long-term vision for the provider's day-to-day practice. So the first thing for ownership is the vendor selection process, okay? EHR certification ensures that a quality product will be selected. So you're not going to buy some bunked EHR because you're going to buy one that's certified. A, so you can get the meaningful use, and B, because if you don't, you're going to spend money on something that's not going to guarantee any improvement in your practice, whether it's financial or patient care. So system selection, you want to select a system based on the organization's current and predicted needs. So, and I know you might think this has nothing to do with me, Denise, but as you move up in leadership in nursing, and even if you're like, I don't want to be a leader, I'm going to go into clinical work, it doesn't matter because you end up getting involved with this stuff anyway. You need to figure out, first of all, if you mesh with your organization's vision, hopefully you do if you work there. And then what are your organization's current and predicted needs? If you are public health and you guys want to focus on that, you're going to want an EHR that caters to that. And not just that, you're going to want an EHR manager, because you don't just buy the program and download it on your computer. You either from within or contract, depending on the size of your facility, a group of people who are constantly going to be molding the EHR around your practice. So there's a few criteria. So common clinical workflows. Okay, so the less amount of instruction for different areas, the better, because when you systematically have similar workflows, it makes things more interchangeable and more predictive. But of course, no clinical area is the same. So you're definitely going to want to look at all your different clinical workflow areas and see what is similar and what isn't. The type of decision support you're going to need. I work in outpatient, so do I need decision support on restraints? No. But if we were connected with a hospital, then we would. Do I need decision support if I have a simple practice that doesn't involve that sort of requirement? No, then maybe I don't need to spend so much money on Epic. I'm going to use NextGen, because all I really need to do is get access with other facilities and keep my CPOE in board, but I don't really need to pull lists because I'm not doing public health projects. Reporting. So what kind of reports are going to be important to your practice? So for anybody who works in the hospital setting, here are the reports that are important. Nosocomial infections, falls, call light times, um, deaths that happen in the patients, restraints, any type of accident, and then also reporting, okay, how many, what's the readmission rate? What's the influenza rate? What's our vaccination rate when people leave? That's important stuff you have to run in order to get grants and to improve things for your hospital in general. There's nothing to do with getting a meaningful use grant, but you know, we're all reimbursed based on our performance and JACO. And so if JACO doesn't like what you're, you know, say you have a high fall risk, it's going to trigger a JACO investigation. Well, reporting is going to help you improve that because you're going to see where and when the falls happen and what process is not being implemented or being implemented not the best, less efficiently, that you're getting more falls. Okay, usability. So this is a big one because if you don't have good usability with an EMR, it's not going to be meaningful. So you have to take that into consideration. Who and what type of usability do you need? Are you a huge organization where everybody's going to be using your EMR down from the clerk all the way to the CEO? That's the case. You're going to need a system that's really, really usable to everyone. And then technical build and maintenance of the system. How much does your software require add-ons? How easy is it to meld it into what your practice needs? And what's the cost every time you want to make a system change? Implementation. So implementation planning should occur concurrently with the selection process. So here's the deal. A lot of places, they'll be like, we went live with Epic, but it happened in stages, right? First, it was inpatient. So the first thing a lot of places did was they just got orders in the computer. Then from there, nurse charting. And the nurse charting, they started in med-surg floors. And then physician charting, and then interdisciplinary charting. And they slowly went live that way. And then by 2012, all areas for the most part went live 100%. And that implementation plan, it wasn't an accident, it was planned ahead. Okay, now we're going to start implementing decision support, and we're going to check and see how it improves our fall risk. Okay, starting this day, this is how it's going to happen. And when you know that you're going to buy an EMR and you think, well, this is going to help us with decision support, and in 3 years, we're going to start using the decision support to see what it improves, you keep that in mind when you're buying something. Initial sequencing of the EHR components to be implemented and resources required. So you got to think about that. What resources are going to be required for the EHR components? Are you going to need hands-on people there all the time, and can you afford that? If you can't, that doesn't mean you're not going to use an EMR, but you're going to have to think about how you roll things out. And then the implementation plan should also account for the long-term optimization of the EHR. This is an expensive undertaking, but it's also permanent. And EMR is here to stay. A lot of people were, I remember a lot of the older nurses were like, oh, the old days, this will never stay. And I still even work with a doctor who's just kind of thinking like, well, our productivity has gone down. So eventually they'll stop using EMR, but we won't. And they're just going to find someone whose productivity stays high despite using computer charting. So part of that is getting buy-in from everybody. If you have unhappy staff with the EMR, they're not going to use it right, and they're either going to go or you're going to have trouble with sustainability with your program. Flexibility and expandability. All right, there's financial and patient privacy hurdles that have to be overcome to achieve the expansive EHR. The Department of Health and Human Services loosened regulations so that physicians may now be able to receive healthcare IT software, hardware, and implementation services from hospitals in an effort to alleviate the cost burden on individual providers and foster adoption of an EHR. So what does this mean? Okay, so when we first started developing EHRs, they were really strict about who can help you and how things get programmed because of the patient privacy. And so providers were like, dude, if you don't fix the EHR so that it answers our specifications of our practice, then we're not going to use it properly. So we're going to need people in there who's helping us. We're going to need to install software that's going to improve our program. So the Department of Health and Human Services kind of went over the HIPAA rules with EMR to make it a little easier to get some system support. So patient privacy is a pivotal issue to determining how far and how easy it will be to share data. And health information exchanges, to reach their full potential, the public has to be able to trust that their privacy is protected. So I actually I did some of my training at this very famous doctor's practice, and she just sold to UC because she really thought it would be great to join a big group. And she was one of those private practice owners that will probably get away with never having to go to a group, which is very rare, just because she does a lot of boutique stuff, and she's well known, she's published, she has all this great staff. But part of her deal with going to UC was that she would have to start using their EMR. And a lot of her patients were like, I don't want to do it. I don't want you to put my stuff in the computer. They're so obsessed that like it was gonna get out there. She ended up breaking off from UC, and she can afford to do it, and she kept all her patients. And she has a very lucrative business, but most people pay cash, so it's a different kind of practice. And those are the practices that can go without an EMR, but most places can't. So despite the challenges, the future of EMRs is exciting for patients and clinicians. A lot of clinicians will tell you no. And for you guys, I'm sure some of you think it's annoying. But if you think about the full potential of what we can get with EMRs, I mean, in quality improvement alone, you don't even have to look at patient stuff. You can look at nursing process. You can find out it got to the point where they were able to figure out how to get the vital signs from the monitor into your Epic flow sheet. How cool is that? That cuts down so much typing time and error. The most significant transformation will come as interoperability between systems. So this is a great example. I'm so glad that everybody in Cincinnati uses Epic in terms of the big hospitals. But I'll get a patient who's like, oh, I went to Ohio GI, or actually Ohio GI is TriHealth now. I think it's like Cincinnati Gastroenterology Group. They're private. They use a smaller EMR. They're not going to use Epic because they're too small. So their electronic record doesn't come into mine. So I don't know anything that happened when that patient goes there. And I'll have patients who said, I got a colonoscopy 5 years ago. It was at a place by UC. It should be in there. And of course, it's not in there. And people get upset because I'm like, we need to find your records on your colonoscopy. You need to figure out if you need another one. And so interoperability is really important. So eventually we'll be able to cross into different groups. There's a wealth of descriptive data available pointing to the benefits of EHR. Nurses have to stay engaged in this evolution, help shape its direction. Because if we want it to go a way that we like, then we got to help shape it. It's already had really great impact on our practice and our patients. Yes, paper charting sometimes is easier, but this is easy too. I thought, and there's so much good that came out of it. We got to cut back on the way we did care plans. I mean, that was amazing. Admissions were so much faster. And you can actually take care of your patients. And then you can also focus on how to improve training new grads. So here's some thought-provoking questions. What are the implications for nursing education as the electronic health record becomes standard of care? What are the ethical considerations related to interoperability and shared electronic records? And those are things that, since this book's been published, it was published in 2012, a lot of this has been covered. But of course, it's always going to have to be improved. But the EMR is here to stay, and it's improving patient care every single day. So, when people said it was a fad, we knew that it wouldn't be a fad. But it is really cool to see how it's helping. And now there's things you can take pictures with your phone of a wound, and it's called Epic Haiku. Import the picture into Epic, send it to another doctor, and you can get a consult like that. And how great is that? I was able to find out that somebody's thing on their finger was actually a really form of invasive cancer. So I was able to, I knew it was definitely not a good looking lesion, but knowing that it was such an invasive cancer, I was able to get someone in to the specialist in a week versus a month. And a month makes a difference with invasive cancer. So yeah, there's some really cool things happening with EMR.